All right, thank you so much for that talk, Dr. Razai. For those of you who don't know me, my name is Bianca Chang. I'm the Assistant Clinical Director of the GI Motility Program here at Cedars-Sinai, and I'm going to be talking a little bit about some updates in gastric physiology testing, so a test that we're offering here, and a test that we'll hopefully be offering here in the near future. And I have no disclosures. So before talking about gastric physiology testing, this is a very brief, very superficial overview of gastric physiology. So when we think about what the stomach is doing and what the different parts of the stomach are doing, the first part of the stomach that we see most proximally is the fundus. The fundus is really responsible for accommodating the meal that we're eating so that we can tolerate more than a few bites or an entire meal. Once the fundus empties the food migrates into the body of the stomach. And the body of the stomach is where the intrinsic gastric pacemaker is located. It's also where food is mixing with gastric acid and where the food is getting mechanically churned and broken down into smaller particle sizes. Those smaller particle sizes then migrate to the antrum of the stomach, and it's in the antrum of the stomach where we have contractions that occur at approximately 3 cycles per minute, which will push the food from the antrum into the pylorus. The pylorus then relaxes and allows food to enter the duodenum where food is absorbed. When we think about the gastric myoelectrical activity of the stomach, this is what is coordinating the motility and peristaltic contractions of the stomach. So again, we talked about the pacemaker region of the stomach. This is where the gastric slow waves originate from, specifically the interstitial cells of Cajal, which again will occur at approximately 3 cycles per minute. These slow waves propagate circumferentially and then migrate distally to the pylorus, again at about 3 cycles per minute or every 20 seconds. When we think about gastric myoelectrical activity, the first test to really evaluate this is known as EGG or electrogastrography. And these are examples of normal EGGs in the fasting and fed state. So in the fasting state, we have gastric slow waves, again occurring at about 3 cycles per minute with some intermittent gastric contractions. When patients eat or they're in the postprandial state, we see increased regularity and amplitude of those contractions. So this is what an electrogastrography looks like. There are 3 sensors that are placed across the abdomen, and this is specifically in the postprandial state. So again, normal postprandial EGG will show those 3 cycles per minute contractions at increased regularity and increased amplitude compared to the fasted state. Bradygastria refers to gastric contractions that occur at a lower frequency, and tachygastria would be at a higher frequency. So as opposed to the sort of more archaic now EGGs with 3 sensors, we are now offering a new technology called gastric alimetry. And instead of, again, using those 3 sensors, this is using an entire panel and array of 64 electrodes, which analyzes the stomach's myoelectrical activity using a technique referred to as body surface gastric mapping. So we'll go into this test in more detail, but it is FDA approved in the United States, the United Kingdom, and New Zealand. So how is alimetry performed? So what does the patient actually undergo? The patient comes to our clinic, and depending on how much hair is on the surface of the abdomen, if there's a lot of hair, then the nurses in our clinic will actually shave the hair so that they can attach the adhesive pad. Then regardless of whether there's hair or not, the skin is prepared with a skin exfoliant pad, and then the array panel is attached and an impedance check is performed to make sure there's a good signal. Once the data starts recording, it will first record 30 minutes of a fasted state. After 30 minutes, these patients will ingest a standardized meal, and for those patients who don't have allergies or dietary restrictions, that meal consists of an Ensure shake and a Cliff Bar. Do not worry if you have a patient who has allergies or sensitivities. There are many alternative shakes and bars that we can give to the patient. So if you're ordering this test for your patient but they have allergies, just let us know what those allergies are, then we can accommodate that. After the patient eats that meal, then the alimetry will continue to record the electrical activity of the stomach for 4 hours. Once the recording starts, the patients are also given an iPad, and during the entire test, they will tell us on a scale of 0 to 10, with 0 being nothing, 10 being very severe, how each of 6 symptoms are. And at the end of the recording, we get a spectral analysis as well as a symptom association. So this is an example of a spectral analysis, and we'll go over the numbers that we see and what they mean and how important they are. One of the most important numbers that we see in the spectral analysis is the gastric alimetry rhythm index, normal being greater than or equal to 0.25. The rhythm index tells us how stable that frequency and amplitude is. Like we can see in this example of a normal, we want to see sort of a yellow line which indicates a higher amplitude, and we want that line to be fairly stable, fairly horizontal. It'll also tell us what the principal gastric frequency is. Again, there's a small range, but we want it roughly to be around 3. It'll also tell us the fed to fasted amplitude ratio. Again, we should have an increased amplitude in the fed state, and normal is greater than or equal to 1.08, and this is adjusted for BMI. So again, this is what a symptom association looks like. Patients during the study are telling us on a scale of 0 to 10 how severe their upper gut pain, nausea, bloating, heartburn, stomach pain, and excessive fullness are. And those symptoms are then correlated with the amplitude of the gastric contractions. If the correlation is greater than 50%, then we consider that to be a significant correlation. So here is a profile of what a normal gastric spectral analysis looks like. We can see that the rhythm index is normal, meaning that there is a stable frequency and rhythm. We can see that the increased amplitude in gastric contractions then goes back to their baseline fasted state after about 2.5 hours. Here we see what we refer to as a neuromuscular profile, and as opposed to that normal profile that we saw where we see a really clean, straight, horizontal yellow line, this one has a low rhythm index, and so there's the amplitudes and the frequencies are sort of scattered, and this is what we see in patients who have a neuromuscular disorder or there's damage to the interstitial cells of Cajal. Here we see what is referred to as a sensory motor profile. So the spectral analysis here is relatively normal. There's a normal rhythm index, a normal frequency, normal amplitude in the fed state. However, in this profile, you can see that the patients are reporting significant symptoms, and those symptoms track very well with the gastric amplitude, so correlation is significantly greater than 50%. When we see this, we think about visceral hypersensitivity as a cause of the patient's symptoms. And here we have what is referred to as a continuous profile. So again, here we're seeing a normal rhythm index, stable frequency, stable amplitude, increase in amplitude in the fed state that goes back to baseline at a normal time. But in this profile, the patients are reporting continuous symptoms. And because the patients are reporting continuous symptoms, there's really no association between those symptoms and the changes in the gastric amplitude. When we see this type of profile, we think about inflammatory disorders or centrally mediated disorders. Gastric alimetry is not a test that is used to assess delay, so it wouldn't replace a gastric emptying test. However, this was a nice study that was actually performed by the Alimetry group, and it was only looking at patients who had known gastroparesis or delayed emptying. And in this population, we saw that 38% of patients had a normal spectral analysis, 29% of patients had a long lag, so the increase in amplitude was more sustained than we considered to be normal. 24% of patients had an unstable spectral analysis, meaning we're thinking there is a neuromuscular disorder going on, and 9% of patients had a high frequency. This helps us because if we know that a patient has gastroparesis and they fall into one of these abnormal groups, then it can help us to tailor therapy, whether that therapy be a prokinetic medication or, for example, more pyloric-directed therapy. Speaking of gastric emptying, I wanted to kind of remind everyone that we also have available in our clinic a gastric emptying breath test. Not a new test. It's been around and FDA approved for over 10 years or so, but we started offering in our clinic a couple years ago, especially with the long lag time in getting patients in for the nuclear medicine scintigraphy. This test uses a carbon-13 labeled spirulina, which is combined with dehydrated eggs. We make patients basically a green egg omelet, and they eat it with saltine crackers. The carbon-13 is then absorbed in the small intestine, it's metabolized in the liver, and then it's exhaled in the breath, which is then picked up by the test. So what is the patient undergoing for this test? They come in a fasted state, they breathe into a test tube, they eat the meal, and then at certain time points, they breathe into more test tubes, and then we send those samples to the lab. This is what you will see with every report, and it shows you what a normal curve looks like as well as what a delayed curve looks like when it's moderately delayed as well as severely delayed. In a normal excretion curve, what we should be seeing is a sharp uptick in the excretion rate, and then we should see a plateau and a decrease in excretion before 240 minutes. Here's an example of a breath test that you may get for a patient, and we can see the patient is at the top, and at the bottom is the normal curve as well as delayed curves. In here, you can see that there's very, very low levels of that carbon-13 CO2 that's picked up at the breath test. You can see this in two situations. One is in very severely delayed gastric emptying, so very little of that carbon-13 is leaving the stomach to be absorbed by the small intestine. You can also see this in cases where the patient does not eat the entire meal. And so if the patient does not eat the entire meal, then this test is actually not valid. So some advantages of this gastric emptying breath test are that it can be performed in the clinic or remotely. These kits can be sent to patients' homes. It does not expose patients to radiation, it's non-invasive, and because of that, it can be used in children, pregnant, and breastfeeding women. Some drawbacks, though, are because it contains egg and there's lactose. It can't be performed in patients with egg or milk allergies. Because of its mechanism of action, it can't be used in patients who have significant malabsorption, pancreatic disease, severe liver or pulmonary dysfunction disease, and again, it is not valid if the entire meal is not consumed. If you're thinking, okay, well, how does this compare to the nuclear medicine gastric emptying test? It compares very well. We see that there is 80% specificity, 89% sensitivity compared to the nuclear medicine scintigraphy test. So you may be thinking, okay, well, I have a patient that 5 years ago, there was a 20% retention rate at 4 hours, and then over time, maybe the patient got better and then they got worse again, or that patient got treated, whether it be with a G-POEM or a pyloroplasty, and then their symptoms are coming back. And you may want to compare a gastric emptying test today to that test that was done 5 years ago. Again, as you could see in the data that we get from these gastric emptying breath tests, we don't typically report at 1 hour or 4 hours that gastric retention, but in 2008 from this paper, they actually did calculations, and we do have an equation to actually give a 4-hour retention for patients who have the gastric emptying breath test. And we'll start reporting this too in our gastric emptying breath test to allow you to compare what would be a 4-hour retention time for patients who get the breath test and compare it to the nuclear medicine study.